Welcome to another installment of the Dutch webinar series. My name is Dr. Kelly Roof, and I'm a clinical educator here at Precision Analytical. In today's session, we're excited to welcome back Dr. LaKeischa McMillan, who's presenting today's webinar called The Estrogen Equation, Dominance, Detox, and Dysfunction. Her presentation focuses on understanding estrogen dominance in midlife women, especially during perimenopause and menopause. It explores the difference between absolute and relative estrogen dominance, the role of ovarian aging, inflammation, and environmental factors, and how receptor signaling, like estrogen receptor alpha versus estrogen receptor beta, contributes to symptoms. She also highlights how Dutch testing can identify estrogen metabolism patterns and impaired clearance pathways that offer more insights beyond standard lab values. And finally, she provides various targeted treatment strategies, including nutrition, detoxification, gut support, supplements, and hormone therapy to restore that hormonal balance and metabolic health. Dr. LaKeischa is an OB-GYN whose mission is to empower women for generations as they age to feel confident in knowing how balancing their hormones is essential to healthy living. She graduated cum laude from Oakwood University in Huntsville, Alabama, with a Bachelor of Science in Biology, and she earned her medical degree at Loma Linda University School of Medicine. Dr. LaKeischa is committed to providing women with the information and the resources they need to experience relief from their symptoms and make informed decisions about their health. If you're ready to start using Dutch testing in your practice, sign up as a registered provider today. It's really easy. Just click that link that we posted in the chat and complete our provider application form. A member of our onboarding team will walk you through the steps to set up an account so you can begin taking advantage of all the education and resources that Dutch has to offer. Plus, registered providers gain access to our entire educational library, including courses like Perimenopause Management, Introduction to HRT, Mastering Functional Hormone Testing, and the Interpretive Guide. Also, you get one-on-one consultations with Dutch clinical educators. This dedicated support and education is, of course, designed to help you become the hormone expert. If you have any questions as we go, please submit them, and we'll do our best to address in a follow-up in the days ahead. So be sure to follow us across all social platforms to stay up to date. It's a pleasure to have you with us, Dr. LaKeischa. Take it away.
Thanks, Dr. Kelly, for having me here once again with your audience here, your practitioners, those of you that are thirsting for knowledge and looking for more. And today, as you have already been told, we're going to dive into the world of estrogen. I know you guys are just sitting on the edge of your seats waiting for that. You know, I've been here before, and it's always a joy to be here. But today, I really want to talk to those of you that are here for the first time, or looking to get some more, or sticking your toe in the water just a little bit more. This little segment is for you because I remember it seems like yesterday, sitting on labor and delivery one night after unfortunately losing my father to complications from a stroke, and then just 10 short months later, losing my grandmother to complications from CHF, sitting there going, I need an exit strategy. My blood pressure was 160 over 110. And those of you that have known my story, you've heard this before, but I want you that are here for the first time that are saying, hey, I really feel like my practice can go to the next level. I really feel like I can help women and men, or I just can help people and take things to the next level. Take that leap. It is so worth it, because you will be there to help others to be able to get what they are looking for. Because I've taken this leap, I've been able to be on multiple platforms, being able to teach people, teach practitioners and the patients what's going on with them during this time in their lives. And so today, what we're going to do, we're going to talk about estrogen dominance, this estrogen equation. We're going to talk about what estrogen dominance is, why it happens in perimenopause, how to test for estrogen excess, and how to treat it. All right, there's some key takeaways that I really want you to be able at the end of this conversation to just be like, okay, this is what we were supposed to take away. What one thing that I would like for you to really hone in on is that estrogen dominance is not just about hormone levels. It's not just about a number. It's about metabolism, receptor activity, and elimination. We're going to go through all of these things today. I want you to know that symptoms persist when clearance pathways are impaired, especially at that phase 3 level. We're going to talk about that gut hormone connection. And then I want you to also start resting in the knowledge and the reassurance that layering functional medicine testing in terms of saying the Dutch test reveals patterns. You're going to start being able to sit and start you're going to start seeming like a rock star, like a clairvoyant, even like that person that can look into a magic ball, even, or that crystal ball, because you're going to be able to use things such as the Dutch test to be able to see patterns, reveal patterns, not just values, not just a number. You're also going to be able to see the why behind the hormonal symptoms. Also know that inflammation, insulin resistance, genetics all contribute to this conversation of estrogen dominance. The goal is not just to reduce estrogen. I know that everybody would love to just jump to that. It's like, oh, if I could just get rid of that estrogen, if I could just get it out. It's going to be so much more than that. It's about looking to rebalance the system and restore metabolic harmony. Here we go. Section 1. Let's actually define estrogen dominance. And in doing so, I'd like you to meet my patient, Angela. Let's meet Angela. Angela is a 47-year-old teacher. She came into the office exhausted, frustrated, and feeling like she was losing control of her body. I often say, these are the women that say, I feel I missed a memo. I think I woke up and missed the email chain. I was not CC'd. I was not blind copied because I woke up in a body I don't recognize, and it feels as if it's overnight. Over the past 8 months, she's noticed the following things. Her periods are getting heavier and longer with large clots and they're unpredictable. Her sleep, erratic. She'd fall asleep okay, but wake up at that 3 a.m. hour with the wired and sweaty. She's the person that tells you she has to use her foot as the temperature regulator now at nighttime. You all know what I'm talking about. They put the foot out because they're too hot, then they have to put it back because they're too cold. They're waking up feeling clammy even. I have some patients that will tell me they will be very insistent and they will say, it's not night sweats. I am not having night sweats, but I am getting warm in the middle of the night. So temperature dysregulation at night. She's gained 12 pounds around that midsection, despite eating cleaner than ever before. And you know who I'm talking about. This is that patient that walks into your office. They're saying, I haven't changed anything. Matter of fact, I've gotten better at making sure that I am eating clean. I'm not eating the junk. I'm really watching my sugar intake. I've actually even decreased my alcohol intake. They are really putting forth the effort, and their weight is not budging, or it is increasing. Her breast feels sore almost every day, and her moods are swinging from anxious to irritable. She feels as if she is on the roller coaster. She felt disconnected from her partner. She has zero sex drive. I say to patients, do you feel like meh about sex anymore? And they're like, yeah, I mean, I look up and it's been like weeks or months even. And I'm kind of like, okay, if this is what it is, that's just kind of how it's going to be. But then they also feel guilty about it if they are also in a very connected relationship, or their relationships were connecting, and they feel like, wait a minute, something is wrong with me. She's been to 2 other providers already. Her labs were, say it with me, you all know what they're going to say, normal. She was told that this is just what it is, welcome to, and fill in the blank, welcome to your 40s, or welcome to your 50s, or this is just how it is. And they give her an antidepressant, or they want to put her on what? The pill. You all know this patient very, very well. So let's talk about, we're gonna have to now define relative versus absolute dominance. Okay, relative versus absolute dominance. Absolute dominance, because all of those symptoms that she just gave you, this whole that whole caveat where she walked into your office, you're now starting to think, okay, there is something going on with her hormones, right? And now you're wondering, is it something that is, she has too much of estrogen, which is this absolute dominance, where now she's starting to have issues with the hormone milieu. And so this is now starting to affect her, and it's coming in like this. What are the symptoms? They're heavy periods. She's gaining weight. There's that anxiety. There's the sleep disturbance. These people even start seeing fibroids on ultrasounds. They're like, I didn't know I had fibroids. What's going on? And this can happen in either both relative or absolute dominance. So let's talk about absolute dominance. Absolute dominance is when you actually can see the numbers, the numeric values inside from the testing that you're doing. And mainly it's usually testing that is done, that is serum testing, right? And so this serum testing that is done usually will show you some numbers. It will show you that a lot of times their progesterone is probably low and their estrogen numbers are usually pretty high. That's with the absolute dominance. So you can actually see some data points there. And that kind of gives you that aha, that smoking gun, that, okay, I got it. All right. And so then you start working on that. Now, the relative dominance, this is where we've got to go a little deeper, and we're going to talk about this a little bit more in this conversation. So why does estrogen dominance happen in perimenopause and menopause? I'm glad you asked. It happens because they now start having anovulatory cycles. And I'm going to show you, I love this graph that I'm going to show you next. And I want you to burn this in your brains, and you can just start seeing this in your sleep. You can start seeing this every time, this graph, where anovulatory cycles, their progesterone starts dropping. And so now you do have, this can either show up as an absolute estrogen dominance or a relative estrogen dominance, because in the serum, when you take that blood draw, the numbers may not quite match what we would like to say is an absolute estrogen dominance. You may not get that ratio that is really discrepant between estrogen and progesterone. But you will see that they are now starting to have these anovulatory cycles. And what happens? So their cycles start either getting further apart, or they start skipping cycles. And so their progesterone is low. So when the progesterone drops, it can give this relative type of estrogen dominance. The ovaries are starting to age. Remember, women are born with all the eggs they'll ever have, period. Okay? And as they go through their cycles, they are recruiting those eggs every month, but only one wins and the others die off. That's atresia, so they die off. Now, when you have this aging of the ovaries, you can have hormonal chaos. This can then contribute to that low progesterone, that anovulatory cycles, right? Okay, you see how this is working? The other thing is also having environmental factors that can actually cause hormonal disruption. You can have things in the environment. We've talked about plastic, we've talked about xenoestrogens that can come and stimulate the estrogen receptor and can cause a relative estrogen dominance. Okay, so you won't necessarily see the numbers in the serum changing. And then this last one, that stress response. Oh my goodness gracious. I could sit here and talk to you guys for a whole, another lecture on stress and the adrenal hormonal function. What I want you to understand here, and we're going to talk about this a little later as well. The adrenal glands, they are super important. They are in charge of our stress response. And as we're going through life, the adrenal glands help keep us alive, right? They are the ones that give us that fight or flight response if we need to make sure that we stay alive, that we need to protect ourselves. If we are out of that situation, immediate situation, the parasympathetic nervous system should be stimulated so that you can reset, you can rest, digest, reset. Now, if you are constantly driving the adrenals in the sympathetic nervous system response, they're not going to be able to do what they need to do as we get older. As we get older, the adrenal glands should take over and start producing some of these sex hormones. And when they can't do that, this can also contribute to this estrogen dominance picture. Here's this graph that I love. Why it happens in perimenopause. So the graph that's up at the top, okay? That graph, this is what happens when women are in their reproductive phase of life. So here's the analogy I always give my patients. Think of your period in terms of grass growing. Estrogen makes the grass grow nice and tall. Progesterone's in charge of the lawnmower system. Progesterone waits around to see if there was an egg fertilized. If there was no egg fertilized, then progesterone says, hey guys, in 2 weeks, we're going to mow the lawn. So it waits around, 2 weeks later, mows the lawn. Depending on how high the grass is will be how heavy the flow. Progesterone also is estrogen's accountability partner. It does not allow the grass to grow but so high. Now, remember I said as they age, we start getting this hormonal chaos. You have anovulatory cycles, and you start seeing where what's happening is progesterone is not always going to hang around like it should. Progesterone sometimes goes, you know what, guys? I'm done. No egg was fertilized this month, but I don't think we need to hang around. So it starts dropping too fast, too soon. Now you have estrogen having this lining just growing. This is that relative dominance, okay? Which can also present as absolute dominance, where you can see the numbers, you can see the discrepancy. But this is what I want you to realize and remember and understand. As a woman ages, as you have your women going through their, the different phases of life, as they get older, the ovaries start changing, the hormonal milieu starts changing, and the levels at which their hormones used to get to, they don't always go up there consistently, and they don't always stay as high as they used to consistently, and they start dropping too fast, too soon. Okay, does this make sense? I hope this makes a lot of sense. Now, remember I said that we also need to talk about the stimulation of the estrogen receptors. So let's talk about the forgotten layer here when it comes to estrogen dominance. We have estrogen receptors. There's alpha estrogen receptors, there are beta estrogen receptors. When you look at the literature, alpha estrogen receptors tend to be pro or proliferative or inflammatory, whereas the beta receptors tend to be anti-inflammatory or regulatory. So think about this as a gas and brake system. Alpha is the gas. We're pushing on the gas. We're pushing on the gas. So we're proliferative. Remember, I said this is what makes the grass grow tall. So you have those alpha receptors in the uterus. You can have alpha receptors in the brain. You can have alpha receptors, as you see here in this illustration here. Alpha receptors are everywhere. And when you have this estrogen alpha receptors, you have proliferation. You have inflammation. But then you have the beta receptors that come in, and they'll push the brakes. They'll say, no, 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 we need to regulate. We don't need so much proliferation. We don't need so much inflammation. So this particular milieu or this particular harmony is what happens for the most part of our lives. Now, what happens when women go into perimenopause? What happens is you actually have more of an alpha estrogen activation. When you have more of the alpha estrogen activation, you are now what? Proliferative, inflammatory. So you have these type of effects, these inflammatory effects. Elevated lipids, cardiovascular changes, or complications, hypertension. Now you have this low-grade inflammation that's continuing to go on, because remember, these alpha estrogen receptors are pro-inflammation. So there's this low-grade chronic inflammation. Now in the adipose tissue, remember, we have white adipose tissue and we have brown adipose tissue. What is happening is that the white adipose tissue is becoming dysfunctional. And when you have that dysfunction, you increase aromatase activity. And when you increase aromatase activity, you actually start producing more estrogen. And we're going to come to the different types of estrogen that we're going to look at when we talk about the testing of estrogen, okay? And now when you have this, you also now stimulate insulin resistance. Insulin resistance, now you have an increased risk of having weight gain, developing diabetes, type 2 diabetes. And do you see this nice little circle? It keeps going on and on and on. And so I say here, think of this almost like a domino effect. Dominoes, they used to set them up, and what happens is they would be these elaborate situations, and when the dominoes would fall, at the end you would either see a beautiful picture, or it would turn into a different structure or something else at the end. And what the key to this, though, this is the key, this is why I love stories, is the interval in between the dominoes have to be at a certain interval, so that when this one falls, it hits that next one and it can continue. I like to think about inflammation almost like dominoes falling. So when you stimulate an inflammatory response, you create free radicals, right, guys? And these free radicals are going around looking for a partner to actually, to be able to connect with, so that they aren't going around creating another inflammatory response. This is that low-grade inflammation. And so we need to do something so that we actually create a bigger space between these dominoes so that the next one doesn't fall. Remember this when we get to another slide, where I'm going to bring this back around when we talk about how we're going to help Angela out. Okay. So think about this. This is this ongoing circle, or these dominoes are continuing to fall. You have this inflammatory process, and this is what sets women up, because estrogen dominance in perimenopause, this is how this estrogen dominance can look, because it can be this relative dominance versus an absolute dominance, because it's now this vicious cycle. All right, let's talk about how do we test for estrogen excess. And if you all didn't know already, I'm kind of partial. I love the Dutch test. And I think it is such a great way to be able to look at somebody's biochemistry on a deeper level. So let's go. And I just want to give y'all kudos to the way that they have set up this test, and they've given it a facelift, and it just looks so beautiful. So here's where we're going to talk about estrogen detoxification. Remember, I said in the objectives and in the takeaways, what I want you to understand is not only why you have estrogen dominance. Okay, you can have, and there are different types of estrogen dominance. You can have the absolute, you can have the relative. Not only that, but we need to see what is going on in the detoxification pathways to make sure that the person is clearing their estrogen. And this can be part of that relative dominance. Okay, so if you look here and you look through how we're able to look at the progesterone side, we're able to look at the estrogen side and the androgens. Here is also telling us that there's phase 1 and phase 2 of estrogen detoxification, or the detoxing pathways. Now here we do see that there is a low progesterone. Yes, it is low. So we are seeing that there is a dip in the progesterone. And if you look here, her estrogens are on the high side. Not only that, we're looking to see which pathways she's favoring. Okay, so if you look, there's the 2-OH pathway, which is protective. There's the 4-OH pathway, which is potentially carcinogenic, and the 16-OH pathway, which is proliferative. Let's sit here for a moment. 16-OH is one of those estrogens that can weakly bind to the estrogen receptors, but it's proliferative. So this is where you can, on serum testing, not necessarily see the numbers that you're looking for to see if there's this absolute type of estrogen dominance. Okay, so you would suspect that, oh, her progesterone's low, her estrogens look like they're all high, but when you look at which pathways she's favoring, it's the 16-OH that she's favoring. And usually when you do serum testing, you're just looking for estradiol, you're looking for estrone. And so you may not see the absolute numbers. That's why we have to be able to have this broader understanding of estrogen dominance here. And if you see here, she's making that 16-OH, and we're trying to say, okay, is she going to be able to even push this out and clear this out? When we're looking at phase 1 detoxification, phase 1 detoxification is where the body has the ability to change the shape of estrogen. Phase 1 and phase 2, okay? This is where the liver utilizes certain pathways in order to change its shape. I say, think of it this way. Estrogen has to change its shape in order to move through the maze. So it's either adding on a group, or it's taking off a group, or it has some partners that come along to help it move through the maze. And this is where this test is really good at helping you to understand what is going on with this particular person's biochemistry. Do they have what is necessary, the support that is needed in order for them to move estrogen through the maze? Are they able to methylate? So you look at that methylation activity down in the left-hand corner. Do you see that? If you look at that, that's telling us, they're not able to really methylate. Methylation is really key in actually helping to get it down to phase 3 and get it out. Does this person have the right cofactors that are necessary in order to be able to help their genetics? Remember, these SNPs are now part of somebody's genetic makeup. This is where medicine is headed. It is headed to personalization, being able to really hone in what is right for that person. So I remember in biochemistry, I'll take a side note here, y'all. I remember being in biochemistry class. So many years ago. That was 1996, I think. Ooh. And I remember the professor writing an equation on the board and talking about how this equation happens in the body in order to be able to give you energy so that your body can produce energy. He says, and there's some other things that are happening. We're not quite sure. There are these other molecules that are helping the reaction to move along. It gives it synergy. Do you all know what those things were? They are your micronutrients. They are your vitamins. They are your cofactors. B6, SAMe, B12, magnesium. All of these things are needed so that your body, so that your patients' bodies can do these reactions and help to detoxify estrogen, utilize the amount it needs, and then flush out the rest that it does not need. Remember, we talked about a couple of things that can happen that can contribute to this estrogen dominance as well, and can contribute to some of these the symptoms that your patient comes to you with. The cortisol pattern is another thing. This is that stress. This is where the stress comes in. And again, why I love using the Dutch test, because it doesn't just look at your hormones, your sex hormones. It also looks at what your body is doing with the stress pathway, because we know that there is an intimate relationship between the two. So this is Angela's slope. This is her cortisol slope. You see how it's flattened, and she's talking about how tired she feels, how she's not feeling like she's rested in the mornings. If you look at her melatonin awakening, it's low. This is also contributing to all of the symptoms that she is experiencing with this estrogen dominance. Okay. And I want you to remember about this as well. So Angela's Dutch test showed that her metabolites skewed towards the 4-OH and 16-OH pathways. Remember, 16-OH is more proliferative. 4-OH, if I can take a time here, 4-OH tends to lead to more carcinogenic type of effects. So you want to make sure that if somebody is skewing towards that 4-OH, we're doing things that help with decreasing that inflammatory response. Remember that. So we're doing things to help to decrease inflammation. She has very low 2-methoxy-E1. That is that methylation activity. And remember, we have to look at some of the cofactors that help methylate. And she has low progesterone. Now, I did not show you her GI map, but on her GI map or stool testing, she had high beta-glucuronidase activity. Beta-glucuronidase is an enzyme that is located in the large intestines. It actually helps to unpackage estrogen if the body thinks, hey, you need a little bit more of that estrogen before we let it all go out. So phase 1 and phase 2, think of them as actually wrapping up estrogen in a nice little bow after it changes the shape. It gets to a certain point, then it wraps it up in a nice little bow, presents it to the intestines, and the intestines go, and uses the scissors, beta-glucuronidase, if it needs to cut, boom, and open it back up again and recirculate. If it's doing that at a high activity, if you're using those scissors too much and that beta-glucuronidase is too high, or that activity rather is very high, this then allows reabsorption of estrogen, and you can have that estrogen dominance pattern again. As I said, her cortisol pattern was a flattened slope, and she had low morning output of her cortisol. This is that woman. Remember, she said she feels sweaty, and actually, what I say is she will come to you, and if you ask her, do you feel wired and tired? She will tell you, oh my gosh, yes, I do. So how do we treat this? How do we treat? We're going to treat strategies to address phase 1, phase 2, and phase 3 detoxification. We're going to support hormonal balance through nutrition and hormone replacement therapy as indicated, and targeted supplements as well. So let's talk about what we did. So remember that phase 1 support. So phase 1, when you look at the Dutch test, that's where that E1, E2, and E3 turn into either 2-OH, 4-OH, or 16-OH. What you can do is you can actually give this patient DIM to help shift the estrogen metabolism towards the 2-OH pathway, because 2-OH actually goes and clears and can be methylated more easily. Okay, so I'll either have my patients do some DIM, either maybe 100 milligrams a day or even up to 200 milligrams. Some people have to go up to 3. That's usually for men, though, that's how high I get with them. I always encourage increasing their cruciferous vegetables, like their broccoli, cauliflower, Brussels sprouts. Can I be a little transparent with y'all today? So I'm part of the cohort with Angela, okay, as y'all saw already with Pause for the Menopause, right? And I am in this perimenopause phase, and it is so interesting. I have actually started tracking when I crave Brussels sprouts. Yes, y'all, I crave Brussels sprouts. I will look up and go, ooh, I need to go get my Brussels sprouts. I need to go roast some Brussels sprouts, and I will eat almost a whole bag of roasted Brussels sprouts. And I actually start feeling better. I notice my mood feels better. I don't have the breast tenderness that I used to have or was having the day or two before. If I really honed in, I feel like I'm sleeping better. So this is real physiology that is happening. So tell your patients, ask them what they're willing to do in terms of incorporate into their diets. So you can say, hey, are you a vegetable eater? Do you eat broccoli? Do you eat Brussels sprouts? Do you eat kale? And if they say yes, then say, you know what, make sure you get at least 3 to 4 or even 5 servings of that a week, making sure that they increase their serving size of these cruciferous vegetables, limiting their alcohol and reduce charred meat. I know I'm stepping on my own toes with this, because as we get older and we're having that estrogen, alpha estrogen receptor activity increase, it actually does impact alcohol dehydrogenase activity. Our alcohol dehydrogenase goes down. That is an enzyme in the liver that helps us break down alcohol. And so we can't break down that alcohol like we used to. So that one glass of wine or that cocktail, it takes longer to get out of your system. When you have that, you are stimulating that chronic low-grade inflammation. So have these conversations with your patient. I have come to find when you start making things more relative to everyday either symptoms or activities, it is more easy for them to incorporate new habits into their lives. And then they don't feel as if you're just telling them no all the time. Okay? So limit their alcohol intake, charred meat, so the barbecues, those type of things, because they can really impact some of the enzymatic activity in the liver and affect that phase one detoxification. Phase 2 support, if you notice on the Dutch test, when you look down, there was phase 2. Phase 2 is that methylation activity. So methylated B12, methylfolate, or COMT support. Those are things that can be added into their regular routine and regimen in order to help them be able to do that phase 2 detoxification. Magnesium, magnesium, magnesium. I love magnesium. And I believe that a lot of us are magnesium deficient, because we know that magnesium is known to be a cofactor in over 400 reactions in the body. Okay, so if you're using up what you have in other reactions in the body, when it comes to detoxifying your estrogen, if you don't have much, that can impact that methylation activity. SAM-E can be used to improve low methylation capacity. And NAC, oh my goodness, I love some NAC, NAC, glutathione. These are the ones that you want to put into place to help decrease that inflammatory response, okay? Decrease that inflammatory response. Remember, putting that space. All right. We're going to come to that. We're going to come to that as well. That phase 3 detoxification, this is the gut liver hormone highway. Oh my goodness. So phase 3, remember, this is actually in when we're talking about the gut. So now we've got to get into the gut microbiome, the gut hormone connection. This is where you can find the beta glucuronidase activity. Beta glucuronidase is that, remember, is the scissors that will come and cut that bow and unpackage that estrogen, and it'll get reabsorbed back into the bloodstream. Now, if that activity is pretty high, what you can do is you can actually have somebody on calcium D-glucarate, which will reduce that estrogen reactivation. It will help to reduce that beta glucuronidase activity so that we don't have too many scissors going around cutting open that bow and opening back up that estrogen. Dietary fiber, oh my goodness, dietary fiber, it has so many properties and so much goodness. It will also, what dietary fiber will do is it will actually help to create the best environment so that certain bacteria will grow properly. When you have that balance in the microbiome, you are now creating an atmosphere, an environment that really does set you up for better estrogen detoxification in phase 3. So dietary fiber, and dietary fiber can then pull some of these toxins and pull that estrogen and push it out of the system. This goes into the next thing, the broad spectrum probiotic, or rebalancing that gut flora. It's all part of that same conversation, Supporting bile flow with lemon water. Love some good lemon water. Doing that first thing in the morning can be very supportive of your gut and your adrenal health first thing in the morning. And I tend to warm up my water so it tastes like a little nice warm tea, especially in the winter time. Take a lemon, you can take half a lemon, squeeze that in that water, and that can help with that bile flow, being able to help with stirring the digestive system, because when we start with a good digestive enzymes in the stomach, then you are now setting up the system from the top, being able to have the right microbes in the body to be able to help with this detoxification. Addressing constipation. When somebody is not eliminating consistently, that is allowing for that reabsorption and that reactivation of the estrogen. So do you see how this is all intertwined? Oh my goodness gracious, this is so good, so good. Terrain support. Reduce high glycemic carbs to stabilize insulin. You can also have them take maybe a glucose support type of supplement to help with that insulin, or to help with that insulin sensitivity, being more insulin sensitive, helping with the gut. Adding daily walks and light strength training. This is where I want to go back to the dominoes. I champion grounding. What grounding is simply, in its simplest form, going outside, standing barefoot in the grass. Because when you do that, you are literally creating that extra space between the next domino. You are allowing the earth to even give you some of those electrons so that free radical that's running around finds its partner. You are helping to decrease inflammation. So simply having someone go outside and ground, it's scientific. It really does work. I remember my son a few years ago. sending me a screenshot of his teacher at school. He was doing some remote learning, and the science teacher was talking about grounding. And he was like, "Ma, we're learning about grounding." And I was like, "Your mother does know something, huh?" So grounding can really help. These are some of those lifestyle or the terrain support that you can implement into your patient's everyday life that doesn't have to feel so ominous that they are really having to do a big overhaul into their lives, but that they can just implement some of those things that they can really just do on a daily basis. Sleep hygiene is very important. And we have to be very sensitive to when we start talking about sleep, because I want to go back to something here. When a woman's progesterone drops, she does lose that ability to help regulate sleep, because progesterone is very influential in our sleep, in the cascading events that happen in the neurotransmitters of helping to go to sleep. So helping to onboard with some bioidentical hormones, which you'll see on the next slide, also helps with that sleep hygiene. So you have to be sensitive to saying, okay, it's not just put the phone away. It's not just turn that off 30 minutes before, an hour before, or making sure you have good sleep hygiene, because a lot of our patients are very aware of that. They know that they should be doing certain things to be able to get to sleep. I often say to my patients, are you bookending your day? You know, we give kids a routine, a bedtime routine. When we're, when we're raising them, we give them a bath, we read them a book. It helps the brain to know, oh, it's time to turn this off and go to sleep and land the plane. That's what progesterone does for women. And when they have that low progesterone, that ability is sometimes lost. So giving them that support, but also helping with the sleep hygiene and mentioning that and making sure that they do have something where, okay, I don't have the laptop in bed. I'm done with the day. I saw a lot of this when we all had to come home, during COVID, where we had to bring our offices into the house. There was no separation between work and the home life. And so we have to make sure if somebody is still doing that, that they have that break. It's like, okay, the office day is done. Even for entrepreneurs, I know entrepreneurs, solopreneurs, they're like, oh my gosh, but my work is never done. You give yourself a hard stop, and you say, I can do these things tomorrow. Okay. And you also then support them. The sleep hygiene, going out and grounding, doing the walks, being mindful, implementing meditation can even be very helpful for some people. Breath work, all of these things put that space in between the dominoes so that we can disrupt that chronic inflammation. Here we go again, that hormone support. So starting her on a bioidentical progesterone, helping to counter that estrogen dominant symptoms and improve that sleep, like I said. So what I want you to remember is the estrogen equation. It's a whole system. So Angela's care addressed production, okay? Balance that with the progesterone support. Receptor activity shifted the alpha estrogen receptor dominance and with an anti-inflammatory diet and gut healing. The detox pathways optimized her phase 1, phase 2, and phase 3, gave her some terrain support to help reduce that inflammation and improve her insulin sensitivity and reduce the gut dysfunction. Angela's outcome, 12 weeks later, her periods were lighter, more predictable, 8 pounds weight loss without caloric restriction, sleeping through the night, no early morning wakenings. Her mood was more stable. She didn't have as much any more breast tenderness. Her energy was restored. She felt like herself again. And I have heard this story over and over and over again with my patients. I have patients that will say, oh my gosh, I I looked up and I was sleeping better. I looked up and I was able to now go to the gym. I was able to feel like I had more energy. So really dialing into the patient and really knowing their story and being able to not just look at numbers. I know we look at numbers, we want that data, and it is very vital. It is also vital that we layer on some functional medicine testing. We understand that there are layers to this situation, and we address all of it to be able to get the best outcome for our patients. It has been my joy and pleasure to be with you again to talk about this wonderful world of perimenopause and this subsection of estrogen dominance. Until next time, see you later.
Thank you so much, Dr. LaKeisha, for that wonderful webinar. We're always so honored to have you speak here at Dutch. So thank you. And thank you to all of our viewers for joining us today. We hope you learned something useful and got some good insights from that webinar. Watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. And if you want to learn more about the research behind the Dutch test, go to dutchtest.com/research and make sure to visit the Become a Provider tab to register for an account so you can gain access to even more hormone education and research. Be sure to follow @DutchTest and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts.